Guys, so today we'll continue our set of lectures of inflammation, and now we switch to the topic of chronic inflammation. So what is chronic inflammation?
I
You
think
understand that acute inflammation is inflammation which made by acute reasons, so acute injury or a bacterial invasion or something this way. But chronic inflammation is when is present when acute inflammation, so a reaction of our body cannot handle it, so cannot eliminate the offending agent during the acute phase of inflammation, and it causes a chronic inflammation. Yeah, additionally, I can say that chronic inflammation might be present. So please, microphones off. So keep
sir,
hands.
excuse me, sir.
Yes.
I want here is so one Aisha Iftikhar, sir. Who
Okay, so chronic inflammation might be appeared de novo, so it might be appeared due to some specific injury, so might be autoimmune injury. So when our offending agent is our own cells, and also it can be present in particular types of inflammatory particular types of offending agents like tuberculosis, for example. Tuberculosis is very rarely cause the acute phase of inflammation. It directly causes a chronic inflammation. So in that, let's talk about this. So causes of chronic inflammation is there. It might be persistent infections, as I said before. So when offending agent is not relieved during the not eliminated during the acute phase of inflammation, so you can say that it will undergo the chronic inflammation. Then hypersensitivity diseases. So it will discuss in chapter number 5. It's immune disorders. So it will be in next set of lectures. Next set of lectures will be about the circulatory disorders. Uh, but and but next but after this after the set of lectures of circulatory disorders, we'll discuss immunological disorders. Then we will discuss it in more details, but keep in mind we have hypersensitivity disease when our own immunity works against the our own cells. That's why keep it in mind. Then prolonged exposure to potentially toxic agents, either exogenous or endogenous. So I guess no need to discuss it. So we have some diseases by which we produce some toxic agents, yeah, and also it might be acquired reasons, so also bacteria or even foreign body which appeared in the part of body. Then okay, let's talk about morphologic features of chronic inflammation. We discussed the morphologic features of acute inflammation. Yeah, so these 5 causes of chronic inflammation, they are stable for any acute type of inflammation. But here we have morphologic features of chronic inflammation. First of all, it's infiltration with mononuclear cells. Infiltration with mononuclear cells, very typical. So I remind you that mononuclear cells are like lymphocytes and macrophages or monocytes, yeah, and they are derived from blood, and they entered into the connective tissue by the same way as leukocyte recruitment goes. Almost similar pathway goes. So okay, you can answer the same pathway. So leukocytes are attracted to the sites of inflammation. Then it morphologic feature is corresponded with tissue destruction. So tissue destruction is so of course is made by offending agent which is present in this area, and also by destruction by our own inflammatory cells. So it's typical. Tissue destruction is typical for chronic inflammation. In acute inflammation, tissue destruction is also possible, but destruction in acute inflammation causes the abscess formation, right? But in chronic inflammation, it might cause. In chronic inflammation, it always causes the tissue destruction in any way. Okay, and attempts at healing. So you remember that in acute inflammation, so when we have so when normal process of acute inflammation over, so it's followed with the healing process. And you remember that alternative macrophage activation goals, and even in chronic inflammation, they cause the healing process. activize the healing process. But offending agent is not relieved. That's why attempts at healing are present, and then we have connective tissue replacement of damaged tissue. So this present with angiogenesis. It's a proliferation of small blood vessels, and why it happens we'll discuss right now. And also particularly goes to fibrosis. So in easy words, I want to say to you what is fibrosis. Fibrosis is overgrowth of connective tissues. So you remember we have loose and dense connective tissues, and they are stimulated and they are produced by fibroblasts. And because in chronic inflammation and in healing process, fibroblasts are activated, and of course it causes the formation of connective tissue in this area. Okay, this is morphological features of this. So here we see. So what we can see here. So here by arrow shown the cells which are responsible for inflammation, like monocytes, and so what here? Chronic inflammatory cells. So okay, it's yeah, of course it's lung, and you see this is lung. So if you remember the histological pattern of acute histological pattern of lungs, so you remember it's composed of alveoli, so very thin alveoli which are neighboring each other. But here in between alveoli, so here we have alveoli and here we have alveoli, so between them we have very thick connective tissue. So it's outcome of chronic inflammation. Sorry, outcome of chronic inflammation. And for example, number B, you see borders between alveoli, as they are not so thick, but between them is collection of immunity cells goes. Okay, 1 minute. So and here is example of acute inflammation. So here you see that borders between alveoli are not so thick as you can see here. So because fibroblast activation has not happened yet, so and that's why it's so acute inflammation is less injurious than than chronic inflammation, because the thick borders between them, so they will decrease the ability to exchange of gases. So, and the actual amount of active alveoli is decreased here. Okay, let's talk about another. Cells and mediators of chronic inflammation. So first of all, so I want to remind you. So first of all, role is role of macrophages. So one of the most important roles. So they are present in acute inflammation and chronic inflammation both. But in chronic inflammation reaction, macrophages which contribute to the reaction by secreting cytokines and growth factor that act on various cells by destroying foreign invaders and tissues, and by activating other cells, notably T lymphocytes. So, in their ability of macrophages to activize the T lymphocytes, it causes the chronic response. So, in more details, how T lymphocytes are attracted to the sites, it's a discussion of chapter number 5. Okay. So macrophages are derived from monocytes, I want to remind you, and they're produced in bone marrow. That's why.
We cannot hear you.
So please turn off on your microphone, sir.
Oh, sorry. So my microphone was off. Yeah. Okay. Macrophages is one of the most important role in chronic inflammation, because they activize the T lymphocytes to this area. So T lymphocytes are T lymphocytes are like active cells in this inflammation, but macrophages, without macrophages, T lymphocytes are not activized, and they are attracted only by macrophages. So macrophages, they are known as mononuclear phagocyte system. Macrophages are derived from monocytes. Yeah, I want to remind you this. They are monocytes, and we have different types of these macrophages. In lungs, they are known as alveolar macrophages. In the spleen and lymph, they are known as sinus histiocytes. In liver, they are known as Kupffer cells, and so in histology, you discuss it, I guess. But a main idea that these cells are numerous and they act in the approximately similar way. So an activation of macrophages goes into two pathways. Is there classical macrophage activation and also alternative macrophage activation. So let's talk about classical macrophage activation. So classical pathway, it's induced by microbial products such as endotoxin, which engage TLR. So remind you, TLR is a toll-like receptors and other sensors which are present on macrophages. And also their activation goes by T cell derived signals. So these T cell derived signals are especially its cytokine is important is interferon gamma. So T lymphocytes. Classical example is viral infection. So viral infection is activized by macrophages. Viral infection activates macrophages and it activates T lymphocytes predominantly, and T lymphocytes then activize macrophages again with the help of interferon gamma. What's the point of this? So actually, when cell is infected by virus, we need to destroy this cell. Yeah, we need to destroy entire cell. We can't destroy only virus. We have to destroy our own cells. And macrophages and classically activated macrophages, they produce NO and radical oxygen species, nitrogen oxide, nitric oxide, and reactive oxygen species, and they upregulate lysosomal enzymes, so they enhance their ability to kill ingested organisms. So not only organisms and even some parts of human cells. And even you remember from previous topics that viruses inside the cell, they can provoke the apoptosis process, which also requires the macrophageal activation, to digest apoptotic bodies. So that's classical pathway of macrophage activation. And we have also alternative pathway of activation. It's induces by cytokines other than interferon gamma, and they are interleukin 4 and interleukin 13. They are produced by T lymphocytes and other cells. So main idea is that alternative macrophage activation goes after the acute phase of inflammation, after the when offending agent is already eliminated. So it used to be. It's normal appearance of macrophages. They are activized after the acute phase of inflammation. But here, and their activation goes by other way, not by interferon gamma, like in the classic pathway, but by interleukin 4, interleukin 13, and their activity of macrophages goes by activation of fibroblast and stimulates the collagen synthesis. That's what I said you before. Yeah. Okay. So products of activated macrophages eliminate injurious agents such as microbes and initiate the process of repair, but are also responsible for much of this tissue injury and chronic inflammation. So normally, so what our body is aligned to? Our body is aligned to deal with acute inflammations. And elimination of acute inflammation, so it's a normal thing for us. So inflammation is present all the time in our body, so you don't mention it. But macrophages, but when they can't eliminate it, so when the macrophages, they working as they used to do this, they start to facilitate the fibrosis and other types of cell repair. So this also will be discussed in the end of this lecture. So macrophages secrete mediators of inflammation. They are TNF, interleukin 1, chemokines, and others, you remember, in acute phase of inflammation. And also macrophages display antigens to T lymphocytes and respond to signal from T cells. So that's regulation. Macrophages are regulated by T lymphocytes, and also they regulate the activity of T lymphocytes. It also will be discussed in chapter number 5. It's immunology. And cell-mediated immunity is considered in this chapter. Okay, and then let's talk about role of lymphocytes. So lymphocytes are they are activized by microbes and other environmental antigens, and they activize the T and B lymphocytes, and they amplify and propagate chronic inflammation. That make chronic inflammation a little more acute. Okay. So, for example, we have so it will be more discussed in later topics, but we have so CD4 positive T lymphocytes. So what does it mean? So we'll discuss later, but just remember, CD4 positive T lymphocytes promote inflammation and influence the nature of the inflammatory reaction. And we have different cytokines, so which are produced by CD4 positive T cells. For example, Th1 cells produce interferon gamma. So I remind you, interferon gamma activates the classical pathway of macrophage activation. Then Th2 secretes interleukin 4, interleukin 5, interleukin 13. So as I said, they activate the alternative pathway of macrophage activation. And also they cause the activation of eosinophils. And now you can consider that Th2 cells and this interleukins, they are responsible for activation of anti-inflammatory response. I mean anti-allergic response. You know that the eosinophils are increased in number, so as response to allergic reaction. And Th17 cells, so they secrete interleukin 17. That's why they're named as Th17. And and also they cause the secretion of chemokines responsible for recruiting neutrophils into the reaction. So interleukin 17 is responsible for chemokine secretion by macrophages, and is present in acute inflammation too. Okay, so let's skip it a little bit. Okay. Other cells of chronic inflammation. Other cells of chronic inflammation include eosinophils. As I noticed before, it's abundant in immune reaction mediated by IgE and in parasitic infection. So IgE mediated immune reactions, are notably they are allergic reactions. And eosinophils are active in this part. From histology, you remember that eosinophils by function is almost similar to neutrophils, and they are also phagocytic in nature. They can destroy material, but they are more aligned to destroy cells, human cells, and also the parasitic cells. So and they can control parasitic infection. Okay. And mast cells. Mast cells is distributed in connective tissue, so they are basophils of connective tissue. Mast cells are producing the histamine and heparin, so which causing the primary activation of acute inflammation. And most effects of acute inflammation we discussed before. So it's mediated by histamine and heparin. Yeah, so histamine and heparin reaction, so which we discussed in the first lecture of inflammation. They are produced by mast cells first of all. But on the surface of mast cells we have IgE antibody. So IgE antibodies, they play a role of membrane receptors. They attach to membrane of mast cell and play a role of membrane receptors. And you remember how receptors work. And so when ligand is attached to receptor, it causes some activation inside the cell. So here we have the same. So when IgE, but what is the ligand for IgE? Of course, it's antigen. And when antigen is attached to IgE, it causes same sequence of events which happened in receptors of cell membrane, normal receptors of cell membrane. And in mast cells, it causes the degranulation of mast cell. Once again, in mast cell, we have granules which are composed of histamine and heparin. And activation of IgE causes the degranulation, so releasing of these vesicles, releasing of these granules into the interstitial space, and due to this it causing the reactions like allergic reactions, inflammatory reactions, and in some cases it causes anaphylactic shock. It will be discussed a little later. So that's how eosinophils look like. Basophils are not visible here. Ah, yeah, this is basophil actually. Okay, anyway, and neutrophils. Neutrophils are so normally they're present only in acute reaction. So as said it before, in acute inflammatory reaction, they're corresponded with neutrophils. But sometimes when chronic infection became more acute, so sometimes we have like its wave like leading of disease, neutrophils can be added to the site of chronic inflammation. Okay, we'll return to this point later. Then let's talk about granulomatous inflammation. Granulomatous inflammation is a form of chronic inflammation. It's characterized by collections of activated macrophages, often with T lymphocytes and sometimes associated with central necrosis. So take a look on this diagram. So I'll try to zoom it. Okay, take a look on this diagram. So here around this, so this is central necrosis. So this is central necrosis, so cells are indistinguishable here. You see masses are eosinophilic masses present inside. It's typical appearance of necrotic tissues. And what we see on the side. So first of all, take a look on, 1 minute. Take a look on these cells. This cell, do you see it? Yeah, I'm drawing it. So this is group of there are cells. There are cells which are known as giant cell or Langhans cell, Langhans or giant cells. These cells are made up of monocytes which are fused together, and they form this multinucleated appearance of cells. So the multinucleated cells, you see, it's a giant cell. And it happened when these macrophages are failed to digest these particles, and that's an opinion. And this is typical cells for in chronic inflammation is response to Mycobacterium tuberculosis. So in tuberculosis, these cells are very common. Also, don't forget about epithelioid cells. See here on this diagram, it's not well visible. Okay, here might be visible. Yeah, this like cells, there are monocytes which are activized, and they form. So here it's not clear appearance, but they are epithelioid cells. Epithelioid cells. So macrophages are so crowded around that they form the epithelioid cell. Okay, 1 minute. So please sound off. Okay, let's continue. Okay, and granulomatous inflammation is typical for tuberculosis infection and also to some autoimmune infections, for example, arteritis nodosa. So in the middle here, in case of tuberculosis, we have caseous necrosis. You remember it from previous lectures. So and chronic inflammation is associated with caseous necrosis here. So that's we'll discuss later. So 322, yes. Granulomas are encountered in certain specific pathologic states. Its recognition of the granulomatous pattern is important because of the limited number of conditions that cause it. In this setting, it's Mycobacterium tuberculosis, Treponema pallidum. Treponema pallidum causes the syphilis, and fungi. So a lot of fungi, they are responsible for this. Okay, and also in chronic inflammation caused by autoimmune disorder known as sarcoidosis. So it so following this disease is resembling sometimes tuberculosis disease leading, but without tuberculosis appearance. Okay. So chronic inflammation. Summary about chronic inflammation is a prolonged host response to persistent stimuli that may follow unresolved acute inflammation or be chronic from the outset. It is caused by microbes that resist elimination, immune responses against self and environmental antigens, and some toxic substances, for example, silica. So it's usual dust. Underlies many medical important diseases. Okay, it is characterized by coexisting inflammation, tissue injury, attempted repair by scarring, and immune response. Then the cellular infiltrate consists of macrophages, lymphocytes, plasma cells, and other leukocytes, as we discussed before. It is mediated by cytokines produced by macrophages and lymphocytes, especially notably its T lymphocytes. Bidirectional interactions between the cells tend to amplify and prolong the inflammatory reaction. And a special type of chronic inflammation is known as granulomatous inflammation. It's a morphologically specific pattern of chronic inflammation induced by T cells and macrophage activation in response to an agent that is resistant to eradication. So as I said before. And now we go to the next part. So I'll try to squeeze this part as fast as possible. It's systemic effects of inflammation. And systemic effects of inflammation, they're mostly are promoted by our own cytokines like TNF and interleukin 1 and interleukin 6, as we discussed before already a little bit. And also they are promoted by bacterial products such as lipopolysaccharides, or might be by viral double-stranded RNA and any other stimuli, of course. So let's talk about the results of this. Now, so result of their action. For example, it's fever. So you know fever. So it's increasing of body temperature, usually by 1 to 4 degrees of Celsius. So increasing of this more, so will damage our cell. It will cause a denaturation of proteins. And due to the denaturation, temperature can cause death of the body, because activity of some enzymes are interrupted, and due to this, of course, cell cannot work anymore. And then, but how is it promoted? It's promoted by pyrogens, and pyrogens might be endogenous and exogenous. And so as we discussed before, lipopolysaccharides. Okay, they are it's exogenous pyrogens, and they are endotoxins. Lipopolysaccharides of bacteria, they are exogenous pyrogens. They stimulate the formation of interleukin 1 and TNF. Interleukin 1 and TNF, and this interleukin 1 and TNF, they are endogenous pyrogens. And they increase the enzymes cyclooxygenases that convert arachidonic acid into prostaglandins, and we discussed it before. Yes, this cyclooxygenases, they are present, as a numerous amount of them are present, and they cause the formation of prostaglandins and other eicosanoids. And first of all, it's prostaglandins. They cause also the in hypothalamus this prostaglandin E2. So causing the pyrogenic effect. And so hypothalamus start to produce pro-inflammatory hormones, which causes the shivering of the body, and that causes the fever. Of course, it might be in chronic, in acute phase of inflammation. So usually in acute, of course. And for example, so to understand it, you need to remember what is NSAIDs. NSAIDs, non-steroid anti-inflammatory drugs. So, for example, it is our aspirin, acetyl salicylic acid. It reduces fever by inhibition of prostaglandin synthesis, and most of our NSAIDs are working the same way. Okay. So how fever contributes to the protective host response remains unclear, but notably we can say that it's the same reason we can't increase the temperature of the body for a long time. So increased temperature might denaturate the proteins and causing the misactivity of these proteins in in their cells, in the microbial cells, and of course it might cause the death of these microbes. But still it's not clear so why it happens. Okay, acute phase proteins. Acute phase proteins are produced by liver, first of all by liver, and they are so it's also the part of response to inflammatory stimuli. So three of them best known, they're C-reactive protein. So you're going to check these proteins in plasma of your patients. fibrinogen, and the serum amyloid A. Serum amyloid A, so we'll discuss the serum amyloid A in immunology diseases, how they cause the amyloidosis disease. Very interesting type of disease, so really very rarely detected in routine examination, but very noble for you if you find this disease by yourself. Okay. What's the role of them? The CRP and serum amyloid, so C-reactive protein and the serum amyloid amylase, serum amyloid A proteins, they bind to microbial cells, which assist in complement reaction. In previous lecture, I explained you the complement reaction. I hope you really understand this complement reaction. But main idea is that they assist in attachment of C3b proteins to the surface of this bacteria and causing the targeting of this cell into the formation of membrane attacking complexes and also into formation of into attraction of macrophages to this area. So that's why these proteins increased in their amounts. Okay. The rest of the things which are shown here, they will be better explained in chapter number 5. Then leukocytosis. So you remember that leukocytes are produced in the bone marrow, and some of a lot of leukocytes are stimulated by same TNF, interleukin-1, and it promotes the formation of new cells in bone marrow. This reaction is caused by colony stimulating factors. So TNF and interleukin-1 causing the activation of colony stimulation factors of neutrophils or basophils or eosinophils or lymphocytes regarding to the needs of the body. So, but you remember that that in acute phase we need recruitment of a lot of neutrophils. So we need to recruit a lot of them, and when we need too many neutrophils in one moment, so it causes the formation of young neutrophils in the blood. So it promotes the releasing of neutrophils, even in immature neutrophils, into the blood, and it causes a shift to the left. So you know that in blood analysis, we have lines like young neutrophils, then band neutrophils, and mature neutrophils, and they are present in a row. And left side, so if shifting goes to the left, so it means that more young neutrophils are present inside the blood, and it is clinical significant for us. By this, we can assume that we have acute phase of inflammation now. Fun with bro. Okay. So other manifestation include increased heart rate and blood pressure, decreased sweating, mainly because of redirection of blood flow from cutaneous to deep vascular beds to minimize heat loss through the skin. It causes shivering, chills, anorexia, somnolence, and malaise, probably because of the actions of cytokines on brain cells. So collectively, these reactions are called as systemic inflammatory response syndrome, SIRS. And when bacteria entered into the blood, so it causes the in severe bacterial infections, it comes to the blood. This condition is known as sepsis. In large amounts is present, and cytokines like TNF and interleukin, so enormously quantity of this cytokines is enormously increased, and sometimes it causes septic shock. So what is septic shock? We'll discuss in next set of lecture. It's chapter number 4. So that's, I think it's enough to say about it. So but you have to know what is sepsis. So summary. Fever is promoted by cytokines like TNF and interleukin-1. and which stimulates the production of prostaglandins in hypothalamus, especially prostaglandin E2, so which causes a shivering and all this excessive heat production by the body. Then production of acute phase proteins like C-reactive protein and others. It's stimulated by interleukin 6, which is, it's interleukin 6 also produced in acute phase of inflammation, and it acts on liver cells and stimulates the synthesis of these proteins by liver. Then leukocytosis, so cytokines like interleukin 1 and TNF stimulate the synthesis of colony stimulation factors in the bone marrow, and it promotes the formation of more leukocytes in bone marrow, or at least precursors of leukocytes in bone marrow. In some severe infection, septic shock, we have its fall in blood pressure, disseminated intravascular coagulation, metabolic abnormalities induced by high levels of TNF and other cytokines. It's known as cytokine storm, and you can hear about it in that one of the causes of death due to coronavirus. It's of course it's cytokine storm. So and actually it's related more to TNF and interleukin 1 activity. Okay, and finally we came to the last part of this set of lecture. It's a tissue repair. So how tissue repair happens? Repair of damaged tissues occurs by two types of reactions: regeneration by proliferation of residual uninjured cells, and maturation of tissue stem cells. It's first one, and the deposition of connective tissue to form a scar. So that's shown on this diagram. So normal tissue when it gets a mild injury. So what happens when mild injury happens? You remember in first lectures in cell is a unit of health and disease. So you remember we subdivide all the cell populations into three types. Yeah, they are. And one of these cell populations are regenerative cell types. So when cells are dividing all the time, so without interruptions, the cells are able for mitotic division. And when superficial injury reaches only the fastly dividing cells, they can regenerate. So the stem cells nearby, they will reproduce them by mitosis, and you see picture normal and picture after the regeneration, it's similar. No more changes are happened so after the mild superficial injury, and that's the best outcome. But what if we have an injury which is much severe than this one? When then a mild superficial injury. So when injury reaches the cells of stable cell population, or of stable cell population, or population of cells which are static cell population, which cannot undergo the mitosis or undergo the mitosis very slowly. So for our body, it's easier to create a scar. So scar is a connective tissue, so it's caused by activated fibroblasts. I remind you, so you remember macrophage activation by alternative pathway goes, and it causes the production of growth factor for fibroblasts. Which growth factors are going there, so we'll discuss a little later. So let's talk about this. Cells and tissue regeneration. The regeneration of injured cells and tissues involves cell proliferation, which is driven by growth factor and is critically dependent on the integrity of the extravascular matrix and by the development of matured cells from stem cells that we discussed before. We have labile tissues, which can, in case of injury of labile tissues only, so of course it will be healed in very fast way. So then we have stable tissues which are constantly present in G0 phase, and we have permanent tissues which always present in G0 phase without exceptions. So, and the injury of these cells causing the scar formation outcome. Okay. So let's mechanism of tissue regeneration. The importance of regeneration is the replacement of injured tissues varies in different types of tissues and with the severity of injury. In epithelia of the intestinal tract and skin, injured cells are rapidly replaced by proliferation of residual cells and differentiation of cells derived from tissue stem cells, provided the underlying basement membrane is intact. So that's epithelial tissues. They are labile cell populations, of course, and newly regenerated cells migrate to fill the defect created by the injury, and tissue integrity is restored. So integrity of cells are restored. That's a main repair. And tissue regeneration can occur in parenchymal organs whose cells are capable of proliferation, but with the exceptions of the liver. So where in liver this regeneration is a limited process. For example, pancreas, adrenal, thyroid, and lung have some regenerative capacity. So even injury of these cells can cause the regeneration. Okay, example. So by example, we can explain the liver regeneration. It's a very specific type of regeneration. Human liver has a remarkable capacity to regenerate, as demonstrated by its growth after partial hepatectomy. So you know that from histology you remember that we have cells like stem cells is there present near the cholangial ducts. These cells are so can repopulate the hepatocytes. So hepatocytes are unable for cell division. They are unable, but we have some stem cell population inside the liver. They're known as cholangiocytes, and they repatriated. So here is the cells near the canals of Hering. So they're cholangial ducts, and now still it's not investigated yet. So it's a point of investigation. So how it's regenerated, but now most common suggestion that it is made by cholangiocytes of liver. Okay, let's talk about repair by scarring. Repair by scarring, so always happened after the inflammation. So I said inflammation might appear. So inflammation, you know. So what's the first activized by inflammation? It's macrophages. Macrophages by classical pathway are activized by interferon gamma, or just by ingestion of bacteria or some tissue injury. So macrophages are activized, and then. But after the clearing of microbes, macrophages start to undergo another process. It's an alternative pathway of activization, and it starts to promote proliferation of cell types, different cell types. It includes if injury is repaired, so if tissue is repairable, if it's possible, if it possesses the stem cells to repair it. So macrophages are producing the growth factors of these cells. But if not, if this tissue, for example, like connective tissue, this macrophages causes the activation of fibroblasts and blood vessels formation. Okay, let's talk about the sequence of scar formation. First of all, it's inflammation. And in inflammation, macrophages are activized and cause the cell proliferation. So in which cells are proliferated in this part? For example, epithelial cells. If it is possible, epithelial cells are proliferated. Then endothelial and other vascular cells are proliferated because of growth factors. It's endothelial growth factor which is produced by macrophages. Then it causes a widespread amount of capillaries here to heal this part, to heal this injured tissue part. But later are activated fibroblasts to produce extracellular matrix which was injured or deleted by injurious agents, and later they will form the scar. And a combination of proliferating fibroblasts, loose connective tissue, new blood vessels, and scattered chronic inflammatory cells forms the type of tissue that is unique to healing wounds. It is called as granulation tissue. So please remember what is granulation tissue. By the possession of granulation tissue, you will consider that that healing is started. So especially if you're going to be a surgeon, yeah, in surgery, when you do the incision of the skin or any other organ, so you're trying to find granulation tissue. So it's a sign that healing is in progress, and this is a sign that a patient is gonna be healed. If not, if you can't see the granulation tissue in this in the incision area, so must be healing is interrupted somehow, and how it can be interrupted, we'll discuss it later. And then remodeling, and remodeling is a final process. So this process, so wait a bit, yeah. So this remodeling, so it's C. It's when fibroblasts keep producing the fibers, and blood vessels they are get not they are not necessary now. So when scar is formed, so because scar is tissue with a little how it's called is little requires of blood. It requires no blood. It requires no oxygen, no nourishment, because they're just proteins. They're deposed proteins, and that's why blood cells are gradually destroyed, and so I mean collapsed, and by apoptosis they are destroyed. So okay, angiogenesis. So let's talk about angiogenesis during these three processes. So once again, started from inflammation, then cell proliferation and remodeling. So first of all, vasodilation is caused by VEGF, vascular endothelial growth factor. Vascular endothelial growth factor is produced by macrophages, of course, macrophages. Separation of pericytes from the abdominal surface and break down the basal membrane to allow formation of vessel sprout. If you remember the blood vessel histology, so you remember that here we have additional stem cells of the blood vessels, which here they named as pericytes. And these pericytes start to make new branches of these blood vessels. And this is promoted by VEGF, vascular endothelial growth factor. And then blood vessels grow inside the inflammatory area. And then migration of endothelial cells towards the area of tissue injury. So that's also part of VEGF activity. Then proliferation of endothelial cells just behind the leading front tip of migrating cells, remodeling into capillary tubes, so as I said before, and recruitment of periendothelial cells, pericyte for small capillaries and smooth muscle cells for larger vessels to form the mature vessel. So, and you see, it's for me, angiogenesis happens due to the chronic inflammation in this area. And that's why in chronic inflammation it's typical to possess the more blood vessels. So here, here is the best diagram which shows it. So when angiogenic factors, VEGF, for example, it causes the outpouching of part of blood vessel to form smaller blood vascular stalk, and it causes the joining of different blood vessels. So that's main results of which we are going to get. And so it's a formation of anastomosis between different blood vessels. And these anastomosis are made by extracellular, so made by pericyte recruitment with the help of VEGF. There are also this same process happens not only in inflammation. The same process happens in the process of our body growth. So in embryology, so same process, same VEGF, same notch signals causing the sprouting of the blood vessels, and that's why we have all the capillary beds we have. Okay, then activize the fibroblast and deposition of connective tissue goes. So they are activized by including platelet-derived growth factor, PDGF. In first lectures we discussed it, in the fourth lecture, I guess. Then fibroblast growth factor and transforming growth factor beta. They are produced by macrophages, so alternatively activated macrophages also. and and they cause the activation of fibroblast deposition. So here they are explained: VEGFs, VEGF-A, NO, fibroblast growth factor, VEGF2, PDGF, and TGF-beta. They are produced by macrophages. So activity of each of these factors will be discussed. So you will learn by yourself, because actually we have no time for this. It's time to stop the lecture actually. Then let's talk about morphology of chronic inflammation. Granulation tissue is characterized by proliferation of fibroblasts and new thin-walled delicate capillaries and loose extracellular matrix, often with admixed inflammatory cells, mainly macrophages. As this tissue progressively invades the site of injury, the amount of granulation tissue that is formed depends on the size of the tissue, deficit created by the wound, and the intensity of inflammation. Scar or fibrosis in tissues is composed of larger inactive spindle-shaped fibroblasts, dense collagen, fragments of elastic tissue, and other extracellular components. Okay, so in pathologists can use specific stains to identify this tissue. Okay, what else? And last point which we need to talk about is factors that impair tissue repair. So get ready to answer this in practical classes. So what impair tissue repair? So it might be infection. So infection promotes the acute phase of inflammation, and in acute phase inflammation, the macrophages are activized in the first way, so in classical pathway, and of course, secondary, alternative pathway is unable to promote. So in diabetes, so actually reason is the same. So in diabetes, so glucose level is very huge, diabetes mellitus, and blood vessels are not growing so fast. So blood vessels are compromised in diabetes, and also also the bacteria will settle on the this damaged tissue much faster, much easier, and it causes the lack of healing. Then nutritional status. Nutritional status, so when a deficiency of some vitamins, especially vitamin C deficiency, so it inhibits the normal formation of blood vessels. So blood vessels require elastic material, and elastic material is made only with help of vitamin C, and that's why its healing of this is impaired. Then glucocorticoids. So glucocorticoids actually they have anti-repair factors, like they inhibit the TGF. So and that's why scar became weak, and we can produce normal scar. And that's why sometimes in diseases which are when we have to prevent scar formation, we sometimes use glucocorticoids, steroids. So same as in coronavirus. Yeah, so I always say this example now, because coronavirus is a so typical example of combination of acute and chronic inflammation. And that's why sometimes when fibrosis goes too fast and lungs are healed wrong, so healed with a scar formation, so we need to stop this formation of scar by glucocorticoids, and we administer them. Mechanical factors. So if we have any wound, so it starts to activize the macrophage by alternative pathway, but then you make injury again. And when injury goes again, so macrophages must activize their classical pathway, and it also causes the acute-like phase of inflammation. So, for example, you have chronic wound on somewhere on the hand, and you just open it, closing this. So that's of course impairs its healing. Then poor perfusion. So when we have vascular diseases, and not enough blood with nourishment enters into the tissue, so of course it causes it impairs the healing, because we require a lot of ATP, we require a lot of building blocks which are distributed by blood. Then when foreign bodies are present in the tissue, so it also provokes the chronic inflammation by not by alternative pathway but by classical pathway of macrophages. Okay, the type and extent of tissue injury. So some tissue injuries are causing the incomplete regeneration and causing the loss of functions. So for example, it is a healing of myocardial infarct. So when we know that usually in it has not it's good outcome. Yes, so scar formation is good outcome. For example, if you have skin damage, so scar, you proud of the scar. Yes, so must be scar is healed, and then no injuries happen to your skin. But in case of heart, so when we have infarction of heart, we will discuss in next lecture. So it's replaced by scar tissue, but you know that function of heart is beating and contraction, but contraction is unable now, and that's why myocardial infarction can cause the functional loss of this organ. Location of injury, so we have different types of locations which also causing the different outcomes. For example, exudate in granulation tissue in our body cavities. So, for example, in pleural cavities, it's very bad for us because lungs can squeeze along this cavity and it restricts the normal breathing process. Okay. And then clinical examples of normal wound healing. So it will be your self-independent work. So please write it down. So your self-independent work, it's clinical examples of abnormal wound healing and scarring. So as I think it's enough for today. Yes, it's enough for today. So let's check attendance. So only 65 students are here. Let's check them. And also Zohaib Gil here because you are not in part. Okay. Okay, thank you. You can go. So class is over. Bye.